Okay, all good afternoon and welcome to the latest in our series of Talking Health discussions. This session is going to be focusing on the NHS and on dealing with a challenging run rate. My name is Astrid Spink and I am the Sectors and Communities Manager for the Health and Public Sectors in the UK. Today's speaker is Dawn Scrafield, who is Chief Financial Officer at Mid and South Essex NHS Foundation Trust and a member of our UK Health Sector panel. Over to you, Dawn.
Lovely, thanks Astrid, and thanks for the promotion there briefly.
Yes.
So hi everyone, it's lovely to join you. I've got a few slides that I just thought might help to aid the discussion and prompt some questions. So by all means, please do use the chat or raise your hands as we go along, if that would be helpful. So the task that I was given was to kind of have a little chat with you around challenging run rates. So I work for Mid and South Essex Foundation Trust, NHS Foundation Trust, and we're an acute provider. Not uncommon in the NHS. We have got a challenging financial position, unfortunately, for a variety of different reasons, and some of those challenges I can talk about as we go through, which obviously influences certainly our run rate. So the first kind of thought that I had in terms of just kind of starting with the conversation is obviously just making sure that we're kind of all talking about the same thing, because sometimes people have different interpretations around what a run rate means. So I think just in terms of a universal view, it's really very basically a series of financial numbers or reflection of financial behaviours over a period of time. So whether it's income, whether it's expenditure, whether it's a net P&L, you know, whatever it is, it's a series, a run rate over a period of time. And obviously the intention from a run rate perspective is to really use that information as a predictor of future performance. And obviously the intention is that we should be able to use a run rate to extrapolate to achieve that. And that's all really based on an assumption that current conditions continue. And obviously in industry such as perhaps manufacturing, obviously there'll be a variety of different factors that will affect that. But essentially for a production line, there's a lot of predictable behaviours, revenue, income, stock. You can predict a lot of the behaviours, and therefore, run rate and the prediction of profit and loss and sales and so forth is perhaps a little bit more stable, although appreciating other factors, Brexit, COVID will have no doubt affected other industries. I guess, it'd be good to perhaps start a question really, or reflection, why you think it might be different in the NHS. And I can see there's a few people that have obviously got NHS tags in their title. So by all means, please do pop in the chat why you think, or pop your hand up why you think the run rate kind of view might be different in the NHS. Give people a few minutes to think about that. I mean, it's interesting. I've been in the NHS for over 27 years now. Scary, goes so quick, and obviously there has been so many different factors affecting the NHS. So yeah, well done, Fran. Yep, various activity interventions. Yep. Waiting list, GERFs. It's interesting because obviously you've picked up there very much the elective activity, so the predictive side of things. But yeah, other thoughts, please do. Yep, COVID, you're right, Hazel, absolutely. Okay, so hold that thought, and obviously if other people have got ideas, yep, elective recovery, yep. If other people have ideas, please do pop them in the chat. So one of the things that when I'm trying to talk about run rate, certainly with our board and with our various finance committee and with our managers and our clinicians, is trying to share kind of what I'm talking about on a very practical level. So I've just got a couple of examples in the next couple of slides around what it is that we're kind of talking about. So in very kind of true accountant style, a series of numbers, you know, as an example for what that might look like in an acute trust. And that dark grey column that you can see there in the middle of the page is essentially what our exit run rate was at the end of 22-23, so £3.9 million deficit. So just, you know, for people that see our board papers or have looked perhaps at board papers, our planned deficit in 23-24 was a £4.1 million per month deficit as we go into across the year in 23-24. So on the face of it, our exit run rate and the work that we've been doing to try and manage that should have been okay for this financial year. But as you can see, just like many other NHS organisations, we've obviously got, you know, significant financial challenge. And our run rate, we look at splitting out with the income, looking at pay, looking at the non-pay, looking at the financing, and obviously that grand total. Now, one of the challenges that the NHS also has is that there's often quite a lot of non-recurrent funding streams, or indeed costs associated with activities that we're undertaking, which is non-recurrent. So some of the mitigations that we've been managing are non-recurrent. So what we've also been doing is trying to flag what our underlying run rate is. So on the face of it, it's sometimes difficult to take at face value what the run rate is telling you just on the very raw numbers. So obviously, this is an accountant's dream. We love our numbers. You can see some spark lines there that help just give a sense of direction of travel. What we've also been doing is trying to look at how it looks from a trend perspective, because sometimes it's difficult to see in the numbers where the movements are going. So we've been using a lot more recently SPC charts to try and show the variation from kind of the target or the mid-range or upper and lower levels. So you can see where there are step changes. So you can see our use of agency, perhaps in one of our care groups, has varied between the lines, but hasn't really, you might argue, is on an upward trend. Obviously, we haven't got enough data points to confirm that that's the case. You can see that we've had some movements with data points that look like it's going down and then it's bobbed up again. This here is actually trends based on our bed base, escalation beds, in fact. So not actually financial values, but what we've done is we've then converted that into run rate costs associated with escalation beds. And you can see that through the use of these types of methods, you know, you can then start to create a narrative around a run rate conversation. And then another area, just as an example of how we look at our run rate and try and convert that more into a story so that we can engage, you know, our clinical colleagues and people who are within the service delivering the care, but also consuming the resources that we spend. We need to be able to talk to them about the consequences of choices and actions. So these are a couple of examples, particularly around pay. And you can see this is effectively in a bar chart, our run rate around pay. You can see how it's increasing. You can see the different categories. And then you can also see where we're trying to focus in on where we've got some of the biggest kind of spend areas in our agency. Now, the reason why this is really important is if I just go back to the run rate page in numbers, is you can see that the area that we've seen the most growth in over the periods, when you look, is pay. and actually pay is our most challenging area within our run rate. So a lot of our focus is around looking at pay, understanding that, so that we can create the narrative. So when we come on to then understanding and thinking about, well, what makes really the NHS kind of more challenging, perhaps, in terms of some of the run rate. So I think the size and complexity of the organisation that you're working in the NHS does play a part to how challenging your run rate might be, so how predictable some of your activity is. As has been flagged in the chat, as Fran said, you know, obviously we have elective activity, and elective activity, you know, as colleagues probably aware on the call right now, is predictable, it's planned. We know that we are treating patients who have been waiting on a waiting list for sadly probably many more months than the intention would be, but that's all planned and predicted. We have a significant proportion of the business, about 80% of what we do in the NHS is on the emergency side, and that's less predictable and a bit more volatile. And for the organisation I work in, Mid and South Essex, we have 3 main hospital sites, and we have a number of satellite sites. We have over 16,500 people, staff, whole-time equivalents that we need to run the business of our size, covering a population of 1.2 million. So that in itself creates complexity, because if you think about the number of budget holders that we're working with, the number of services, and the complexity of how some of those services are delivered, that adds a challenge to perhaps the simplicity of a production line that deals with perhaps, you know, a small number of products that can be managed and, you know, and predicted in a much more controlled way. I think the other thing that is quite challenging in the NHS is the complexity and the inconsistency of some of the funding streams. So there is obviously a political angle to the NHS in terms of the funding streams that comes through government, down through NHS England, through Integrated Care Systems, or ICBs is the statutory body, and then out to providers. So there's a little journey for that resource to come into hospitals, you know, into our trust, for example, as a frontline service. So in the main, probably about 80% of our funding comes quite clearly through that route. But up to about 20% of our funding can be quite variable and often given to pump prime services, possibly to do with education, because of the way in which our education might be related to research and development. There might be some private practice activity that we might provide, but that means that some of those income streams are not predictable. And certainly, if we've been given pump priming funding with specific rules, so again, Fran popped in the chat there around elective recovery fund. You know, that's an incentive scheme at the moment to incentivise NHS organisations to increase the volume of activity for elective recovery. And regrettably, there's probably not enough time to talk through the specifics of that, but that is a very complex set of incentives to encourage that, which means that run rate is less predictable. The other thing we have in a challenge with sometimes is retrospective payments. So income streams might be adjusted to reflect future anticipated costs, but then later on, for example, the pay award comes in later on in the year, which means that you get a blip in the payment. So if you just briefly have a little look there, you can see that in the well, let me just see which month is it. So you can see there that we've got the increase in costs in September, and that includes the backdated payments for pay inflation. So that means when you're looking at a run rate, you have to then think about the smoothing impact of some of the actions that have happened, but sometimes the matching doesn't work. We talked about the variation in activity, and again, Fran, you flagged that, but that's only a tiny part of the issue. So emergency activity, as I said, is probably about 80% of the volume of patients and variation that we're trying to deal with. And when you've got high volumes of attendance through your ED and your length of stay, sadly, is increasing because your discharge capability, because of community and local authority support to be able to care for patients leaving hospital is limited, it means that you then have to deal with higher pay costs because we have to put on additional sessions for our nurses or healthcare assistants to be able to deal with that care and demand inside the hospital walls. And that obviously sometimes is not predictable, depending on sickness and staffing as well, or indeed, the weather conditions impacting. So, for example, respiratory in the November season traditionally, in paediatrics and so on. So all of those factors impact then the volatility of activity, impact the capacity for elective, because our emergency takes precedence, and that obviously has an impact then on some of the temporary pay costs, which we then end up incurring. Things like national health priorities, elective recovery post-COVID is a really good example of that. And effectively what we're trying to do is recover waiting lists that have grown over that COVID period by creating more capacity and effectively doing more activity in the same period to what we previously did, at a time where as a nation, as a population, our own kind of views about how we want to manage and deal with our life and our working options is changing. And therefore you've got the impact of a change in expectation of workforce, a change in expectation of the public in terms of the services they receive, and therefore the market or the cost associated with delivering care, trying to respond to the demands and the expectations of the workforce, is really challenging. And obviously that, often has a political angle as well, which you're then trying to marry up capacity and the cost and the premium cost of that. And that kind of then knocks on to the point about workforce. So in the NHS, at least 70% of our costs generally are made up from our biggest asset and our most important asset, which is our workforce. So we're completely reliant on the capacity of our clinical workforce to be able to meet the demands of our population. Now, often we rely on the training pipeline and the availability of that workforce, and it's not an overnight fix in terms of if we need more, for example, the critical care situation during COVID, we had to work through how we would create additional capacity to be able to respond. And that required some intense training and looking at different approaches to skills that were needed to be able to care for patients. Now, ordinarily, you need surgeons, you need ologists of different, whether it's oncology, diabetology, and so on, and they take years to train. So if they're not available, then the premium cost of pay is higher because you need that capacity to meet the demands of your population. And at the same time, if you've got a workforce that increasingly is mindful that we're here, we want to balance our work and home life better, and a lot of people have got that reflection post-COVID, then that means that perhaps there isn't that flex within the workforce in perhaps the same way. I think systems and processes from organisation to organisation really does affect things as well. So good processes, good controls, good governance means that you have got a better chance of managing and improving your run rate. As an organisation that merged in the height of the pandemic, so April 2020, we became Mid and South Essex. Prior to that, we were three separate organisations, means that we've got a variety of different technology systems that don't naturally knit together. So we're still in that process of integration. In a manufacturing example, in a company that perhaps has been established and grown, you would be using good management information data structures. You'd have that management information in a way that could improve perhaps some of those decisions, and that means that you can control potentially some of your run rate. In the NHS, we know that technology is something that is being improved and invested in. We only need to think about our own experiences as patients or people that we know that have experienced the NHS. If anyone tries to get an outpatient appointment, our experiences are all different, and that's because we haven't got good kind of infrastructure, which is obviously changing, but it takes time, and that impacts things like run rate, because productivity and the way in which we deliver services is impacted as well. And then it's just the behaviours and the attitudes. So is another massive factor to making the NHS challenging. So perhaps in the private sector, there is much more of an obvious and clear link with a profit motivated set of actions, bonuses, or that holding to account around the profitability or otherwise of the service that is being provided, or the goods that are being created. In terms of the NHS, it's obviously a public body, which means that the way in which the service is run, it's there for the needs of the population, which means that in terms of the budget holders and the people that are looking after the resources, often people are interested in ensuring that they're providing the best possible care, the most accessible care that they possibly can to care for their patients. And sometimes that means that the managing the money is not top of the priority. And that's not to say that people aren't mindful of public funding, but people are wanting to try and maximise the best for their patients. And that's really challenging, because obviously we need to balance managing the budget, the resource, with the activity, and therefore driving productivity with good outcomes, good clinical outcomes. And that's obviously a challenge. So just my last kind of little slide, and then you'll be pleased to know, Astra, I'll stop there. So just a couple of hints and tips, really, and by no means can I say that we've got this cracked, because, as I said, sadly our trust is in a deficit position, but just some of the things that we are trying to manage. So before you start trying to use your run rate, just make sure that it is normalised. So as I said, sometimes there are blips, and if there are things that look a bit odd, make sure that you're looking at those and understanding, was that a one-off, was that relating to prior periods, and do we need to kind of smooth or adjust for non-recurrent actions? So before you're trying to compare. Isolating your key drivers is something that you'll find to be helpful, because otherwise with a sea of numbers, sometimes unless you hone in on the things that are creating the biggest challenge. So I mentioned for us it's pay, and that's linked with things like escalation capacity. So thinking about what's good management information for the people that are actually controlling or driving the capacity or the cost associated with those things. Do people understand the connection between the choices or the decisions that are being made and the financial consequences? Clarity on what is expected. We are looking to reduce the run rate, and sometimes people get confused between looking at budget performance and run rate. And obviously, for some people, they say, oh, but it's in my budget. But actually, when you look at the budget doesn't reflect what's expected to be delivered. So when we're talking about run rate, we're talking about actual kind of costs or income or real numbers, rather than a plan, which is might not be comparable. In ensuring that you've got that simplicity of message. for people that are used to managing obviously budgets or costs and managing activity every day, perhaps numbers is their thing, but often you'll find that people working in the NHS are not always numbers people. They're very much about patients and care, which is great, but obviously we need to keep it really simple so that people can do the job that they need to do and help improve, drive the improvements in terms of use of resources. So focusing on the right things is really important. Obviously over the years there's been a kind of provider, commissioner, purchaser kind of split, the competition or collaboration type opposition. Very much where we are now in the NHS is focusing around that collaboration. One system pound, one NHS pound for our population. You can't spend it more than once. So very much how do we make sure that in the NHS we're focusing on improving the cost of care rather than trying to generate income, which isn't something that is sustainable when there's one set of national funding. So making sure you're focusing on the right things when you're looking at your run rate to drive an improvement in your bottom line. I guess on a very practical level for people that are in the audience or listening to this who work in management accounts or financial management teams, it's not uncommon where errors happen, when you're processing a monthly journal or monthly data upload, and actually, need to make sure that where there are transactions that are likely to have perhaps a month-end blip in a run rate, that you look at those to just check out, have they been processed correctly? So is there a QA process? And obviously look at process reviews, because sometimes they happen because the complexity of what you're trying to put into your reporting means that errors are more often happening. And then doing that data sampling, so checking, getting independent, someone else looking who's impacted in that reporting helps. Just to make sure that kind of consistency and run rate understanding is shared, because the last thing you want, and it's happened to me before, is that you get a report and you're looking at the report and you're thinking, well, this doesn't make sense, and then you realise that human error, and of course the reporting's all kicked out and you've kicked off a set of actions to try and correct things before you know it. And then just in the NHS, I mean, I really would like to get to a place, the utopia for me is that we should be able to just use our run rates in a kind of really flawless way. But unfortunately, the way in which we're operating, unfortunately, it's almost certainly flawed. So you can't just take your exit run rate and just extrapolate. So I would encourage anyone thinking about kind of looking at run rate, particularly in the first instance, is thinking about those scenarios. What does a best case, likely case, worst case look like? So you've got a bit of a range as you're working through perhaps some of the variations in what might be impacting your run rate. And that means you can then get managers to focus on where the biggest risks are and to try and take that appropriate recovery action. So I'm going to stop there, Astra, if that's okay, and stop sharing, and happy to kind of have a bit of discussion with people if there's reflections, or does that resonate with what people are experiencing, or have we got anyone from industry perhaps who kind of thinking, why is that the case? Or, yeah.
Oh, that's wonderful. Thank you so much, Dawn. Much appreciated. A really good, thorough overview there of the issue in terms of, just clarifying the definition, looking at a few examples, and then some guidance on how to sort of manage the run rate most effectively. So thank you very much.